I'm Mike Barnes, and as Dee said, I'm the managing attorney for DCBA Law and Policy in Washington, D.C., and we work with healthcare service providers as well as addiction treatment programs and laboratories and some pharmaceutical companies, and just want to make sure that you're aware that as I speak today, that I'm speaking on my own behalf and not on behalf of any clients. I will be sharing information, public information that I've learned through the work that I do with a number of these healthcare service providers, and I hope that is valuable to you. Today I intend to discuss policy pretty broadly, and if you'll bear with me, what I will do is go through some overall trends that I see, discuss some themes, and then provide my analysis and conclusions in the form of recommendations. Understanding that this audience is here because you want to stay at the cutting edge of providing quality care in a way that is accessible, ideally in many instances through insurance coverage, and you want to be here and present and serving the public as necessary over the medium to long term. And so my recommendations are going to be directed largely towards some practical and tactical things that you should be doing starting today, and then some more strategic things that you can do to compete in an area where there are some other commercial interests that are ahead of the game and are making progress faster than the addiction treatment industry is making. So I want to make sure that you understand that with the overdose crisis and the changes that I've referred to, there is very aggressive action on the part of other fields in the addiction treatment space, and very effective lobbying that is not occurring necessarily in the areas that we have represented largely at Axis, thinking about heavy psychosocial focused and a heavy residential focused in addiction treatment and more broadly mental health. But the methadone programs are well represented and are making progress. You can see that specifically at the federal and state levels with specific bills and policies. The outpatient buprenorphine treatment providers are probably the most aggressive in this field and have made tremendous progress just over 2 years with some efforts that are publicly disclosed through the news media, and you can see fingerprints on the work that they're doing, but that is going to form the basis. Their lobbying efforts and the impacts that they're having form the basis of a lot of the discussion that I will lead today in looking over the trends that exist in your field. And then there's also a good amount of effort on the part of one more than the other manufacturers of addiction treatment medication. Specifically, the long-acting naltrexone manufacturer has been very actively engaged in the states and at the federal level in making good progress at expanding access to that medication through stated policy at the state and federal levels, as well as through criminal justice programs and drug courts. That has obviously impacted the action at the federal and state levels, and we should also recognize that the insurance industry is a major factor that we need to consider as we're discussing strategy and the policies related to addiction treatment. They are emboldened in a way that I think they have not been in years past. And again, we are seeing that they are doing very well financially. They're doing very well with policy and with their lobbying efforts and their public affairs and public relations efforts. And they're also making the lives of treatment program executives very difficult, and your industry is having a hard time adjusting to the way that they are manipulating the scenario. So we'll talk about that as well. So in response to overdose, largely the opioid crisis, there's been aggressive legal action, and we've seen that on the part of the government as well as the part of insurers and the private sector broadly. So we see some copycat moves. For example, it was announced last week that the federal government is going to be joining the lawsuits against the opioid manufacturers that have been largely driven by private plaintiffs' attorneys and state and local governments, and that's sort of a copycat move by the federal government. But we also know that the federal government has been very aggressive at enforcement and taking healthcare fraud statutes to a level that allows the federal government, first and foremost, to collect the revenues associated with these legal actions, and then also address the crises of overdose related to the improper prescribing or the exploitation of consumers by improperly and unnecessarily billing for medical services. Last week, we heard that there's going to be yet another new task force coming out of the Federal Department of Justice. They're going to be using more healthcare fraud statutes to go after, as they expressly mentioned, for example, laboratories that might be improperly billing the federal government for their services. The federal efforts have been pretty lucrative and productive, looking even just at 2015. $2.4 billion collected in judgments and settlements, and that's divided between the Medicare Trust Fund and the U.S. Treasury, and then individuals who were able to collect through those efforts. Great deal of cases, and I think that's going to be increasing as part of these enhanced federal efforts. Sessions went straight to it in 2017 with his enforcement measures. This headline from last summer was related to going after the prescribers, inappropriate prescribers of controlled medications, also included some of the improper referral relationships, even down in Palm Beach County with their Sober Home Task Force. And then there has been, at the local level, coordinations, as we've talked before at Access about the task force in Palm Beach County being the first, and it's been replicated now related to recovery residences. Federal government has coordinated with the local prosecutor there, and it has been in the news for nearly a year now for being very aggressive, and has also now gone to Congress last year at the end of the year in December. Congressional hearing on what's going on related to recovery residences, driven largely by the Palm Beach County Task Force. And then we see, as a result of that congressional inquiry and interest, now CARA 2.0, the legislation that was recently proposed as a follow-on at the federal level to prior CARA legislation, would create a new national standard for recovery housing. So there's a lot going on that is building to this notion that this field is fraught with fraudulent and abusive actors. And understanding, as you all do on a daily basis, that when you're dealing with health insurance companies, you're oftentimes dealing with algorithms, or you're dealing with people who are paid to go through scripts on telephones. You're not dealing with your peers. You're not dealing with individuals who are ASAM physicians making decisions based on the ASAM levels of care. You're dealing with people who are just reading scripts and looking at papers and making these sorts of decisions. And so the insurers are equally uninformed as they're determining whom not to pay or whom to seek recoupment of prior payments from. And so there's a lot of activity now where the laboratory and treatment field is not just not receiving payment, but actually now having to defend to keep payments that were already paid to them by the insurers. And this is, again, I think, very tied closely to what's going on with all the scrutiny on the field. There's, within this community, within the Access community, a lot of discussion about one of the treatment providers that had a difficult time getting paid by a health insurer and actually sued the health insurer, and then within months was raided by the federal government. And then you can debate whether or not factually this treatment provider was following the standard of care or best practices, or whether or not you believe they were fraudulently or abusively billing. But the fact of the matter is that the government came after them for violations of the Federal Anti-Kickback Statute, but they don't even participate in federal health care programs, right? So again, we've got an aggressive prosecutor here and investigators at the federal level getting the permissions to be able to go in and raid a program on information that isn't even factually correct, or perhaps even ignorance as to whether or not this program factually is subject to the laws that they're using as a reason to raid. Right? So I hope that all of us will ultimately review the final disposition of these cases, whether they be the criminal action or the civil action against the insurer. But in the meantime, you can take lessons that you need to be very careful, and you need to recognize that, as I've already stated, the insurers are very emboldened. They'll just say we're not paying, or they'll say that we believe that what we paid you was too much, and you're going to have to go through an expensive defense. This comes as today I just pulled up the 5-year stock value histories of the major insurers, including Centene, the owner of HealthNet, which is the program that the California treatment provider sued for non-payment. They're doing very well. And so, given where we are with federal health care reform, state efforts at insurance reform, not really much is happening to make the insurers more accountable to consumers, to protect the consumers from the exploitation of insurers that are collecting their premiums but not paying out when these consumers have a need for the services that they thought they purchased with a health insurance plan. They're thriving financially. They're following the government's lead in very aggressive legal action, refusing to pay, demanding repayment against treatment programs, against urine drug testing labs, and they have the greater resources to litigate than you all do. And this is something that I've heard repeatedly from not just the treatment programs, but from the billing companies that work with the treatment programs, and numerous of them, that there is a real threat now that in light of these aggressive tactics of insurers, that it is difficult to see how in some cases the companies will be able to stay in business. And so this is something that you all have to be aware of and prepare for as you think about how to stabilize your industry as well as your companies, your organizations, in a fast-changing environment. So we know from MedPro, had a chance to speak with the CEO of MedPro yesterday. She's saying that what she's witnessing in her role as a patient advocate even is that insurance companies are just unilaterally saying, we'll pay $275 or less for what would be on the low pricing scale on the CMS side, $750 or more worth of services on a daily basis. And so there's no way that a viable, legitimate treatment program can provide quality services in a way that meet individualized needs with these sorts of financial pressures. Something's going to have to give, and it's going to be the quality of care. The question is, are you willing to do that, and is that in the best interest of the patients? No. Is it in the best interest of your industry? No. So how do you respond? How do you proceed? I've got some recommendations for you. And obviously, out-of-network providers are even more disfavored than in the past because of these unilateral payment and pricing decisions of the insurers. Moving on to another trend that I think impacts the residential treatment programs and those that are focusing heavily on the psychotherapy aspects, the therapeutic non-medication aspects of treatment, and those that actually have a goal of enabling someone to be medication-free when that person has succeeded in treatment and recovery. So we know from Dr. McCann's Katz this morning, who in the course of her 20 to 25-minute presentation said twice that for individuals with opioid use disorder, that the standard of care is medications, those that are FDA approved for opioid use disorder. She said it twice within 20 to 25 minutes, and this is a part of the SAMHSA tip that came out and hasn't been widely publicized quite yet, but has some important things that are of interest to those of you that have programs that are not heavily founded and premised upon a treatment with medications. Again, these slides will be available to you. You can look up the Tip 63. I encourage you to do it. It's a long document, but if you look at this slide, you can look at, find some of the key areas. But the main point here is that what the government is saying as it relates to the standard of care will have a major impact on what the standard of care actually is. So SAMHSA has also come out with 5 signs of quality treatment. And just from a practical business perspective, how would your company actually reasonably expect to operate in a market without satisfying SAMHSA, which is the nation's federal agency that really focuses on addiction treatment, without satisfying these 5 signs of quality treatment. I think it's possible for the residential treatment programs that are not heavily medication focused to be able to meet these 5 signs of quality of treatment if you have the appropriate partnerships, plans, and policies in place so that practically speaking, you can meet these 5 signs of quality treatment without veering significantly from your clinical or your business model. Just over the last week, we've seen additional movement on the federal government's part, and this is even in addition to Dr. McCants-Katz having said this morning that the federal government under the Trump administration is going to be continuing to talk at the very high level a great deal about access to medications for opioid use disorder. The FDA is looking to expand medication-assisted therapy for opioid use disorders. They are going to look at what the labeling for these sorts of medications will be, and potentially this will be a good thing broadly for the field as you look to track and report outcomes. If the federal government on the medication side is saying, we're going to recognize outcomes that are not complete, permanent, ongoing, continued without interruption abstinence from all substances as part of our recognition of the value of medications, then you can do the same thing as part of your recognition of the value of the services that you provide, recognizing that relapses are oftentimes a part of the treatment and recovery process, but there are other benefits to treatment that can be reported to show the value that your treatment programs are providing. So this is not necessarily a bad thing if your field is aggressive enough and strategic enough to take these opportunities and make good use of them, like we know that many in the addiction treatment industry and the other sides of addiction treatment are doing for their commercial purposes. And this is where I think you're significantly challenged in your current resources. I don't even think that you need significantly additional resources to do this. Your current resources are not being optimized to be able to take advantage of opportunities like this to draw the parallel and use it to your own advantage. So the Hill reported from the HHS Secretary, again, referring to what the federal government is doing to advance access to medications for opioid use disorder, that if you're trying to treat opioid use disorder without these 3 medications, it's like trying to treat an infection without antibiotics. So they want to raise the number. Currently it's at 1/3 of treatment programs provide access to these medications, and they're going to be focusing on that. It doesn't mean that you need to have somebody who's prescribing or dispensing within your residential program or your psychosocial treatment program, but it does mean that you should have, again, the plans, policies, and practices in place so that an individual who could benefit from that can have access to that medication and still benefit from the extraordinary and exceptional psychosocial services that you might be providing in your program. And going back to Dr. McCants-Katz's statement that medication is the standard of care for opioid use disorder, I don't know that that's necessarily the case. I think that her saying it and SAMHSA saying it makes a very strong case. The legal standard of care is actually determined on a case-by-case basis in each legal proceeding, and it's drawn from things like the SAMHSA tip, federal and state guidelines and recommendations. It can also be drawn from the medication's labeling, which might be something to consider as the FDA is going to be broadening the labeling for these medications for opioid use disorder, professional associations practice or prescribing recommendations, and expert testimony in an actual case. The facts in the proceedings are drawn from the medical records and witness testimony, so obviously that documents the need for there to be very thorough medical records as it relates to each individual. And in the instances of these criminal actions, which oftentimes look to the standard of care if there's a controlled substance prescription involved, the facts in a case could also include the testimony of an undercover law enforcement agent, and cooperating defendants. So in the case of opioid outpatient buprenorphine treatment programs, that might be somebody who comes in and is willing to work with the DEA saying, well, my healthcare provider didn't follow this best practice or standard of care, and I was able to get these medications in a way that was a little too loose. So these are things to bear in mind as it relates to how the standard of care can be influenced in a legal proceeding, and deviations from practice or prescribing recommendations, those sorts of guidelines like the SAMHSA tip really need to be documented in the medical record. So the legal standard of care obviously can be fast changing. For those of you who are really up to date on efforts to reduce opioid use and overdose, you know that for the past 3 to 4 years, the CDC guideline for prescribing opioids for chronic pain in the primary care setting have been heavily pushed at the federal and state levels and through a number of organizations, and they are largely now the standard of care in primary care treatment of chronic pain. That was really fast. Again, it's not absolute, but it is likely that it would be very difficult for a defense attorney to support any deviation from that. The standard of care also then impacts an insurer's determination of medical necessity. Right? So if you look at Cigna's definition of medical necessity, for example, they go to the scientific evidence published in peer review medical literature, which is generally recognized as credible by the medical community, and then specialty society recommendations. And we'll talk more about the value that ASAM has to you currently and strategically moving forward, because as part of the ASAM continuum of care, the programs that you have are center of the table of the levels of care, and prominently included as part of what should be a full continuum that even the government is saying should be offered as Medicaid, for example, adjusts its treatment policies. So looking at your professional societies and the medical scientific literature is going to be very important strategically and tactically. Something that you should be aware of related to coverage and payment in a parallel, again, if your field is strategic in following these sorts of examples and applying them to your own interests, on the pain side, we see that there are heavy efforts now to provide coverage of the non-opioid and even non-pharmacologic treatments for pain. So in Indiana and Georgia, for example, there are bills that would require coverage not just of the opioid pain relievers, but also those alternative therapies like massage, PT and occupational therapy, acupuncture, or chiropractic, if they are medically appropriate in accordance with the healthcare provider's discretion. The same thing could be applied if you wanted to make sure that the types of services that you provide are counterbalanced in this environment, especially as we understand that there might be some changes to parity as, under the federal law if the Affordable Care Act is effectively repealed, and that is a potential outcome in the near term. In 2017, 6 states passed legislation to cover acupuncture, for example, and these are sorts of things that, understanding that pain and addiction are often very intertwined, might be integrated into your programs as well. But again, some parallels that could be drawn as it relates to the non-pharmacologic, non-controlled medication treatments that can be given priority for insurance coverage by state law in the absence of federal leadership at this point on issues of healthcare and insurance reform. Another thing that you all should be aware of is that if you have patients who are interested in conveying their input on the value of medications or the right to proceed in treatment without being forced on medications, the FDA is asking individuals to testify, individuals with opioid use disorder. On April 17th at a public meeting, they're going to be looking at the effects of diseases on these individuals' daily life and the adequacy of available treatment options. So I'm sure that you can be certain the treatment programs that offer methadone and buprenorphine or long-acting naltrexone will have their patient advocates represented at this FDA meeting. Will the residential treatment field or those programs that are heavily focused on the psychosocial aspects of treatment, will they be represented? That's something that the leaders in this room can have an influence on, again, without significant additional expenditure of resources. So, related to federal law and the lack of action at the state level on insurance reforms, there's a great deal of uncertainty. And for those of you who have been at prior access conferences, we've talked about the impact of the Affordable Care Act on your programs, and we don't always agree, but I think what we can generally agree on is that because of the Affordable Care Act, a number of individuals have access to insurance coverage through the state insurance exchanges for individuals and small businesses. And we know that under the Affordable Care Act now that there are essential health benefits that include behavioral health, mental health, and substance use disorder treatment coverage, and that the ACA regs actually expand the notion of parity, which under law is only applicable to larger health plans that choose to offer substance use or mental health benefits. The ACA regs expanded that concept of parity to the exchange plans. Well, if the Affordable Care Act is to be repealed, and we know that there is an effort by 20 state attorneys general to put an end to Obamacare. This is a headline from just a couple of weeks ago. And then we know also that there's been tax policy and now regulatory policy that the Trump administration is taking in order to allow access to these skimpy health plans, as some call them, others call them junk plans, that do not offer significant levels of coverage consistent with those plans that have the essential health benefits. That's going to draw away some of the people from the exchange markets, and largely it's expected to increase the premiums even more in the exchange markets, creating a greater level of instability. So is this going to lead to the implosion of these markets so that then the law will be repealed in its entirety and replaced or not? Will it be a reversion to pre-ACA insurance exploitation of consumers? Well, the treatment industry stands to be impacted very significantly if essential health benefits and the concepts of parity to individuals in the exchange no longer exist, right? And all of this is coming at a time when consumers are starting to recognize the value of the Affordable Care Act, and insurers are actually now starting to stabilize in the market and seeing a path to financial viability, partially, I think, because some of the pent-up demand for health insurance, for health coverage that existed and was being met by the insurers on the exchange at the beginning of the Affordable Care Act, that's been satisfied. We also know premiums have risen to a level where there, at this point, is a greater level of stability. Some insurers are actually saying that they could even lower premiums in the coming year, but that's unlikely. I've worked on a pro bono basis to put forth recommendations to deal with the lack of leadership, frankly, at the national level. My colleagues and I are trying in every effort that we have in evenings and weekends to fill the void of leadership that, frankly, those of you should have been a part of. The treatment field should have been a crucial part of the discussion of federal health care reforms to make certain that coverage for pre-existing conditions, coverage for those essential health benefits, including behavioral health and prescription medications, addiction treatment, that those types of protections remain available to people on the exchanges, and that the exchanges remain actually available to consumers in the states. The annual and lifetime dollar limits. There are ways to enact either a reform or a replacement of the Affordable Care Act that preserve these protections for consumers, but also implement more market-based approaches that don't rely on mandates, for example, but rely on heavy incentives and look to the market and look at sort of the traditional conservative approach to healthcare reform as it preliminarily existed from the Heritage Foundation years ago. Right? So the fact that the addiction treatment field was largely absent and remains absent on discussions of healthcare reform, and specifically these insurance consumer protections, that's a lost opportunity to provide greater stability to yourselves, as your programs, and the patients that you serve or could serve in the future. So I would encourage you, again, to be more strategic with your resources. I know the addiction treatment field has resources in Washington, D.C., and I'm not criticizing the individuals who are working on this or who are leading this, but I do think that there is a much better strategic, thoughtful approach that can be just as effective as the insurance industry has been, and just as effective as the other representatives of the treatment industry have been, without significant additional resources than what already exist. So if you look at how those resources are being deployed, this is something that came out of an Avalier health study published on Vox. It's looking at, the headline is something like, how are states doing in responding to the overdose epidemic? And they look exclusively to the number of buprenorphine treatment providers in a particular state. And that's how they're judging success, that one small aspect of state policy as it relates to the overall crisis that we're in, with a lot more complex issues than just whether or not someone has access to buprenorphine. Forgetting even the underlying issues that drive demand for addictive substances in the first place, right? But that study was commissioned by someone that had a really good PR firm that got this onto Vox, which is a little bit more oriented toward the left, eager to get something out there, but not thoughtful about what came out. And it made headlines. And it made headlines that then reinforce to the governor of Virginia, the governor of North Carolina, that when that state is poorly evaluated at a national level by a credible entity like Avalier, irrespective of who funded it, and it appears in Vox, making that governor look like he or she is not being serious about this crisis, that governor is likely going to tell the task force in the state or encourage the legislature to take action. The legislature is also going to want to take action, and they're going to do what it was that was deficient. In this case, they're going to address the lack of office-based opioid treatment in their state. All right? So why is it that it's focused exclusively on this element? It's because that specific group of entities that have a commercial interest in this were pursuing this in their own interest without coordination from the broader field, because that doesn't serve their financial interest, right? So if you want to do it for your commercial interest, or if you want to do it for the public interest, you at least can merge the two in many cases, and that's what I enjoy about the work that I do with my clients, is there is a way to be able ethically to merge the public interest and commercial interest to make a difference and allow you still to make a living, right? So you don't have to feel as though you're doing something wrong if you're taking these tactics, if you represent the types of discussions that we're having at Access, looking at, again, individualized health care that is appropriate for each person based on unique circumstances in each case. So we also look then at the impact of this very effective lobbying effort on the IND exclusion. IMD exclusion, this is allowing Medicaid to provide treatment to more than 16 individuals in a residential facility. This was the #1 recommendation of Trump's opioid commission, something that Patrick Kennedy has heavily pushed. Patrick Kennedy is publicly recognized that he's working with entities that are interested in expanding access to buprenorphine treatment. And so he was a member of that opioid commission. The IMD exclusion is something that represents the benefit of being active and strategic about your deployment of resources, but it also actually creates a short-term aspect of safety for the access audience for this market of treatment programs that want to focus on residential services as well as the psychosocial aspects of recovery, because what the IMD exclusion policy coming out of CMS and the federal government does is it says that in order to be subject to this waiver that the Trump administration is actively pushing, and we had the Secretary of Health and Human Services 2 weekends ago saying to governors, why haven't you asked for waivers to be able to access the resources to be able to provide treatment in facilities that have more than 16 beds, saying to break it out, if you want to do other things with Medicaid, pull this out, we'll approve it quickly. But the great thing is the guidance out of CMS says that you have to offer the full services under the continuum of care that's set forth by ASAM. Right? So if you draw from those CMS resources and find that there's oftentimes a copycat measure from private insurance looking to what CMS is doing, and they typically do that on pricing, for example, why can't they also do it now on making sure that they are providing access to, through their networks and through their policies of coverage, this full continuum of care that CMS has said should be represented in its entirety among these states and their Medicaid programs that are seeking this waiver. So the CMS put forth an entire guidance document and this crosswalk that states can use. This is an example that CMS put forward that states can use to identify where there are deficiencies and what they need to do to provide greater access on each level of care according to ASAM. So again, ASAM here, as it currently exists with the ASAM continuum of care, is a very good friend and ally of residential treatment and of the psychosocial aspects of treatment. That's not to say that there are not individual leaders in ASAM that are interested in advancing medication first and foremost, either out of a philosophical perspective or practice-based experience or potentially their financial interest based on who their employers are, but the organization as a whole has a continuum of care that is very beneficial to this audience. So, looking then at how insurance companies can be held to that standard, we see that insurance companies are trying to get the headlines for being proactive and responsive to the issues of addiction and overdose, having come out just last fall saying that they've made this commitment to address the opioid crisis. Here, they have made reference, if you look at the greater details of this commitment that these insurance companies have made, there is a reference to the opportunities to have access to the full continuum of care. So you all should do your best to hold them to that to the extent that you can, and that includes a media campaign and push to the extent that they are not adhering to their promise. Again, better utilization of the resources that you already have out there for purposes of making sure that there's fairness in access according to what everybody's already agreed, but we know in practice they're not following. So my recommendations, I break them down into tactical as well as practical recommendations. There are opportunities that have been discussed largely as we've heard from Dr. McCants-Katz and the PTAC purpose in being here from the very get-go. There are new opportunities to engage in interventions, warm handoffs, and referrals to treatment, whether they be in the emergency department or through these crisis centers that we heard about this morning, or through the bond hearings that we heard about on Sunday night, or other areas before a person is arrested and processed and put behind bars. Get that person the treatment that he or she needs, and you'll improve the outcomes and reduce the costs. Mental health and substance use disorder reforms, the types of changes that we heard from Dr. McCants-Katz this morning, embrace those. Try to do whatever you can to get access to the funding that will soon be available in even greater amounts. Do the types of things that show the value of your care, and that includes embracing not just McCants-Katz's, but the broader effort, the social effort to really address criminal justice reform and incarceration, especially as it relates to incarceration of people with mental health and substance use disorders. So continue the types of collaborations that you are making with first responders, police chiefs, as well as sheriffs and the law enforcement community broadly. Expand those to the emergency department, expand those to make sure that your community has a crisis intervention center. Do the things now, take advantage of this moment, that as terrible as it is for addiction and overdose, provides opportunities to create a healthcare infrastructure that can last in perpetuity. Individualized care. So make sure that you have the policies and practices to accommodate the people who will need medication, right? Because you do not want to exclude those individuals from your program at a time when the government is continuing to push, public awareness is going to increase, and there's going to be an expectation that someone have a little help in a medication-focused society in getting the clarity and dealing with the withdrawal symptoms in order to be able to focus on the superior psychosocial aspects of treatment that residential programs provide, or that your programs that have that psychosocial focus provide. So that means that you have to make sure you've got policies and practices in place to comply with controlled medication laws related to storage and dispensing. If someone brings in medication to the program, how do you keep that from being stolen and diverted by somebody else in the program? What do you do to ensure medication safety without violating controlled medication laws? You need to work with competent, experienced legal counsel on having these types of policies and practices in place. You might consider the new practitioner-administered medications that are not susceptible to post-dispensing diversion. If once a week or once a month an individual who's participating in your program gets an injection in a healthcare provider's office, you don't have to worry about pills being in your program. You don't have to worry about all the issues related to medication storage, potential diversion of the medication supply, the impacts on the individual who doesn't then have the medication and can't get a replacement dose. All of that disappears if you take advantage of the technological advances as they are coming to market. And then be prepared to connect individuals with the resources for other primary care and other co-occurring disorders that might be present in the individual on a case-by-case basis. And that includes making sure that you engage the person to be very active after your engagement in residential treatment or whatever level of care you're providing, so that there be outpatient treatment after you've done that continues long-term. And then, as I mentioned on Sunday, we know that one of the major accrediting organizations is working with ASAM, the American Society of Addiction Medicine, to provide certification to those programs that are able to incorporate medication or individuals who need medication into their programs. Beyond that, I don't know specifics of this particular new undertaking, but I would encourage you, as soon as it comes out, to be aware of it and try to do what it takes to get that certification in addition to your current accreditation, so that you can prove that you are one of the organizations that provides quality treatment, as SAMHSA has set forth, that helps you with your marketing purposes, it helps you generally with your compliance purposes as it comes to being able to defend payment, as well as defending any potential challenges to your providing the standard of care and any negligence action. So look at this and start taking the steps now practically to ensure that you are compliant, that you are one that can advertise that you meet these SAMHSA standards and do that honestly and ethically. You have the practices in place to make sure that you can do that in a compliant manner. Strategically, as I've already stated, this field needs to be much more effective in its lobbying and media activities, much more strategic. Understanding that the exchanges could go away, they could collapse. Essential health benefits could disappear if the states don't pick them up, assuming that the federal government could reform health care without requiring coverage of behavioral health care or prescription medications or pre-existing conditions, for example. And parity as it applies to the non-large group plans that are already offering behavioral health, that could also disappear if the ACA regs are repealed, and parity then does not apply to the exchange plans to the extent that they even exist. So be active in the healthcare reform debate. We have a reprieve that thankfully, as it relates to these specific aspects of healthcare reform, there was not a repeal without a meaningful replacement, regardless of which side you're on politically. It is possible to be able to implement Republican-oriented or more market-oriented reforms to healthcare that still protect consumers in these ways, so that people will have access to insurance coverage when they need it, given that they've paid for it. highlight the distinctions between drug dependence care and drug dependence treatment, using the terms of my former boss, Dr. Andrea Barthwell, recognizing that there might be just some care for somebody by giving that individual a medication and saying, okay, you've been treated, versus giving that person meaningful treatment that will enable him or her to engage and achieve long-term sustainable recovery, which ultimately, in that individual's case, it might be a recovery that does not include any medications. All right, so make sure that you highlight that there is a difference between just handing a film or handing a cup of medication to somebody once a day or on whatever dosage schedule, and real treatment that actually meets the needs of the individual, addressing the underlying reasons for that person's substance use in the very first place. Preserve and advance residential treatment as an essential component of the continuum of treatment. So, for example, going back to ASAM and its continuum of care, make sure that ASAM continues to recognize the value of residential treatment and the services that you provide beyond just medication. Ensure that you fill the medical scientific literature with the data that proves the value of your programs, and continue to engage with professional societies so that when they implement guidelines that your programs, models are included, and engage with policymakers in a much better way than the field has been doing. And keep residential options desirable and accessible long-term, because I still maintain that given the instability that exists in our healthcare market, we could have a couple of outcomes in the pretty near to medium term as it relates to health insurance. We could see a collapse and reversion to where things were before the Affordable Care Act, where insurance is in many cases meaningless, despite the fact that people pay premiums and expect coverage. Or we could see a little bit farther down the road that there would be an effort to put into place a concept that is like Medicare or Medicaid for all, perhaps phasing in with a Medicaid option that could be bought in and moving from there, where we have basically government-rationed health care. And we can be certain that in that scenario that it's not likely that there's going to be residential treatment or these psychosocial services that you're offering that would be covered adequately, just like we know already insurance companies are rationing care in a way unilaterally that excludes many of the services of the access treatment providers. So make sure that to the extent that you can, if you've got these programs, that you make them affordable to working families, recognizing that they could be necessary on a self-pay basis at some point in the medium term. And this is in case our parity protections are weakened, as I mentioned, or the government insurer rationing basically means that they have to go back to an exclusive self-pay basis in order to access these services. So I am available for a discussion if you have any questions. We've got a microphone. I appreciate the opportunity to be here at Access, and certainly would love to continue working with you for the year to come before we meet back here again next year. And best of luck in the work that you're doing strategically and tactically over the coming months.
The kind of incidences that we're experiencing with the insurance companies, with the retro reviews, with the clawbacks and all that, is that something that the insurance companies are doing throughout healthcare, or have they seemed to have targeted primarily substance abuse?
No, I just in reading generally health law summaries, there are other areas where this has occurred as well, but I think that there's a heavy amount of focus on substance abuse in maybe one or two other areas. So this is not just this field.
And in that light, is there any avenue then for, because there's kind of a disconnect between the government, rightfully so, wanting to see more treatment for mental health, serious mental illness, and substance abuse, especially opioid abuse, and the fact that the insurance companies are actually making it more and more difficult for providers to provide the care and get paid for it. Is there anything that can be done that can be a connection between that? Is that something that SAMHSA will probably stay far away from, or could they perhaps be involved in some way?
I think that SAMHSA would likely stay far away from that, because that goes to the bigger questions of healthcare reform. And we know that this administration hasn't really had a plan to replace the Affordable Care Act, especially not one that includes these meaningful consumer protections. And so if you're looking at access, either through Medicaid or through private insurance, it has to be a part of a system that makes sense economically, and there's no plan for that. So I think that we're going to continue to see piecemeal funding, piecemeal claims that they want to advance access to treatment, but not the systems really to support that. It's just going to be little programs and dumps of money in very untargeted ways.
Good to see you, Michael. Big fans here. Could you go back to your point where you were saying, frankly, you didn't understand why more of us were represented better to back your efforts, and maybe give an example or two of what that might look like?
Yes, and I don't mean to be critical of the people who are doing work in this field, because I know there's a lot of passion, and I know that there's a lot of hard work and effort and a great deal of history among a lot of the people who are active in policy. So what I do believe is that we can be much more strategic. We can take advantage of opportunities that are currently existing to co-opt, if not ride on the coattails of some of the other treatment programs, treatment industry representatives that are pushing hard and making progress on their particular objectives. And then again, taking a role where in the context of healthcare reform, for example, we only heard, as it relates to essential health benefits, the discussion of pre-existing conditions coverage. Why, in the context of an overdose epidemic, was there not a discussion of the benefit of coverage for behavioral health, specifically addiction treatment, when all the stories were about what this would mean, even about the federal government being willing to throw more money at opioid overdose? There was no discussion about the real impact in a system where people are supposed to have insurance, and insurance is supposed to cover these sorts of needs for individuals. So I think there needs to be a more big picture, strategic approach to the major issues like healthcare reform, but also then the opioid-related issues, and they can then trickle down to have an impact on all of the substance use disorder treatment field.
So, last question, would you say that that might look like the banking industry has the American Bankers Association, the medical industry has the American Medical Association? I'm not sure what that would look like.
It would look like a treatment provider that is either well-financed or that is profitable would fill this role. As we've seen on the outpatient buprenorphine treatment side, there is one primary actor that is having a major impact on things like the top recommendation for the President's Opioid Commission. It could be that C4 or another entity like C4, it could be National Association of Addiction Treatment Providers, whoever has any sort of resources available to be able to have an impact on policy needs to be more strategic, recognizing that there is a plan that can be implemented. And again, irrespective of politics, it can take care of the individuals who need treatment for substance use disorders.